Thank you very much, Dr. Madhur and Dr. Dilip, for giving me this opportunity to speak to all of you. I think it is a great initiative by our team because knowledge is something which we gain. It's never wasted. It can be utilized in a very different way. And now, as a team, what plan we have as a project to deliver best of the success rates for our patients. So we thought of that this is a good idea to have a common platform where we can learn about different aspects of infertility and management strategies for these all situations, so that it is easy for us as a team from Oosphere that management should be strategy should be uniform across the all the centers. Now today we chose to discuss about anovulation, and I'm sure now by this time you are seeing my screen. Am I? Do you see my screen? Just wanted to confirm.
Yes, Kundan, we can see it. We can see
Okay,
it.
fine. Thank you. So, friends, today we are going to cover about anovulation. And I think by this time, many of you know this subject very well. Probably some part of the presentation might be repetition for you, but I tried to do a complete angle coverage of this subject so that we understand the pathology, we understand the investigations to be done, and we understand the management strategies which will give us the maximum success rate. So let's begin with definition of anovulation. Just a minute. Okay. Yeah. So it's a very simple definition that there is an absence of follicular growth and ovulation. That's called anovulation. Now, when we say a treatment part of our anovulation, it is ovulation induction is the treatment for it. But we know that ovulation induction can be offered in anovulatory women and can be offered in a ovulatory woman, that is called as unexplained infertility. But we are going to discuss about anovulatory woman today. And whenever we see anovulatory, so typically any patient who's got anovulation, she will present to you and give you one important finding in your history taking, and that is that how much is her duration of menstrual cycle. So the rule is very simple, that whenever a follicle ovulate, after the ovulation, there is a progesterone production from corpus luteum. So corpus luteum life is 14 days. So there is a progesterone production sustained for 14 days. After 14 days, there is a cessation of progesterone production. So blood serum levels of progesterone falls, and that's a trigger for menstrual shedding, endometrial shedding. So if a patient is ovulating on 16th day, she's going to get her menses on 30th day. If she's ovulating on 20th day, her 14th day, she'll get menses on 28th day. So that's called regular cycles. So, but if a patient is not developing follicle, there is no corpus luteum, there is no progesterone production, and there is no progesterone withdrawal, and there is a sustained production of estrogen all throughout, because estrogen also comes from fat. So we have to remember that there is still estrogen levels in your blood, in a patient's blood. So that's why there are no withdrawal of estrogen. And of course, there is no absence of corpus luteum, so no progesterone withdrawal. So she don't get her menses. So she will always give you history that my menses are late. Now, how late is significant? What is the cutoff? So anything above 35 is an anovulatory cycle, because there is some entity called as a delayed ovulation. So sometimes patient ovulate on 18th, 19th, 20th day, 21st day. But if it is last 21st day, she'll get her menses by 34, 35 days. But many cycle duration more than 35 days is usually anovulatory. Okay. That is one. But is it true for all patients? No, not necessary. Sometimes patients are getting anovulatory cycles, but they get menses in 30 days. Even that is possible. It's the percentage patients are very less, but remember, more than 35 days. So that's how you identify. So whenever you identify such patients, what next thing which comes in your mind is what are the possible causes. So one is a PCOS, second is a thyroid dysfunction, third is a hyperprolactinemia, and fourth is a insulin resistance. Now, if you look at how physiological, I mean, this is just to give you idea that in early adolescent age group, like suppose she got her menarche, but initial for first year after the menarche, the cycles are more than 90 days cycles, means anovulatory cycle. That's perfectly physiological. We don't need to investigate these patients, especially in 1 year after the menarche. Okay. Menstrual intervals persistently less than 21 or more than 45 days, two or more than two times in a year after menarche is also considered as a ovulatory dysfunction. Okay. And lack of menses by 15 or 2 to 3 years after breast budding is again considered as a anovulatory cycle. So that's the earliest in adolescent we can diagnose ovulatory dysfunction. As I said, delayed menses, typical one very important history. Menstrual intervals either persistently less than 21 days or more than 35 days. Sorry for that printing. More than 35 days and more than two cycles in a year also is sufficient enough to say that she's got an ovulation. And again, the typical word which our textbook uses is regularly irregular menses. This is what in a history taking we can elicit and diagnose this patient on typical questions regarding menstrual duration. Now, let's begin with PCOS. So, this definition now PCOS is very simplified. I remember in 2003 and 4 when we were learning PCOS, or all of you must be there by that time. So, see, the PCOS was considered always a complex syndrome. This is also there, that is also there. There were 7, 8 criterias. But now, after so much evidence and consensus meeting, now only three things are required, and out of three even two are present, we can say patient has a PCOS. So one very important history is a anovulatory cycles, which we have already discussed. So history can give us. Second is a polycystic morphology of the ovaries, means you put a transvaginal probe, you see more than 20 follicles in each ovary, that's PCOS pattern. And in case if these two things are there, it's enough to diagnose PCOS. But still there is one more to help in case there are, I mean, no PCO pattern on the scan, but there is an ovulatory cycle and she has a clinical or biochemical evidence of hyperandrogenism. So what is clinical and biochemical evidence? We'll in few slides we'll discuss about it. So what are those potential mechanisms which are leading to insulin resistance in these patients? So that is one thing which we need to understand, because in PCOS, insulin resistance is one of the first event which happens. Okay, so there is something called insulin receptor serine phosphorylation. Now, because of the increase into this phosphorylation, there is a decrease in the protein kinase activity, where that actually leads to insulin resistance. And basically because of this increased phosphorylation, there is a modulation of activity of P450C17 cytochrome 17 activity, which is produced more in both in adrenal as well as in ovarian steroidogenic tissue, and that leads to increased androgen synthesis. So remember, simple, insulin resistance leads to hyperandrogenemia. So this equation, keep it in mind. Now there is very strong link between insulin resistance and PCOS, as I said. So what happens in insulin resistance is a hyperinsulinemia, and these high insulin levels, they decrease the SHBG production. So sex hormone binding globulin is reduced, which is produced in liver. So because this guy binding globulin is reduced, there is a free availability of free testosterone in circulation more, and that leads to hyperandrogenism. So that's one. As I said, because of that insulin receptor serine phosphorylation, there is a increased androgen production from ovary, that also contributes into hyperandrogenism. And due to high insulin levels, there is a disordered LH and FSH release, which is happening because of high estrogen, in fact. And that also leads to, because of high LH, there is a high androgen production from the ovarian stroma. So ultimately there is a hyperandrogenism, and all this can lead to anovulation and PCO pattern. So that's the simple way to understand how insulin resistance triggers PCOS. And this insulin resistance usually is a genetic inheritance from parents to the girl. Now, as we have now seen that increased LH, which is secreted by anterior pituitary, this LH stimulates ovarian theca cells, and there is an increased androgen production by theca cells. So there are high androgen levels in PCOS patient. This is one way of pathway, which is like a pathophysiological pathway. The second is there is a decreased FSH level relative to LH. Why it is there is a decrease? Because there is a high estrogen. So the endocrine principle, that estrogen always inhibits FSH and always stimulate LH. So there is a decreased FSH because of hyperestrogenemia in these women. So because of which ovarian granulosa cells cannot aromatize androgens to estrogen, and there is a decreased estrogen levels, and that's why in fact the decreased FSH level leads to inadequate follicular recruitment, and that actually leads to anovulation. So this is what is two important events which we see in PCOS patient: high androgen levels and anovulation. Now, I was talking about diagnostic criteria and the third parameter, clinical and biochemical finding suggesting of insulin resistance or hyperandrogenemia. So, first thing is here in this, if you look at these criteria, the first is a glucose tolerance test. So, as soon as you diagnose the patient, the first investigation which you're going to send it is glucose tolerance test. It has to be the part of your first investigation basket. So whenever you have fasting blood sugar more than 100 and 2 hour blood sugar more than 140 is you can diagnose them. So remember, even the fasting is very important. Sometimes even fasting blood sugar comes as 104 and 105. Yes, you have to consider that she has insulin resistance. Though the 2 hour value is, I mean, higher side of the normal. But any cutoff which is beyond this cutoff is the insulin resistance. Now, why should we do? Why can't we directly start insulin sensitizer? So simple, 10% of PCOS patient has a diabetes. They don't have not only insulin resistance, they have a diabetes. So you will not be able to diagnose such patient, and that's why it is important that you do GTT in all PCO patients. Want to know who has it, who do not have, or who has the insulin resistance, or who has diabetes also. So that's also very important. So one of the criteria is GTT. Second is obese is a one of the clinical finding, or you check the waist to hip ratio. You check for subcapillary skin fold or acanthosis nigricans. It's typical black thick skin on the nape of the neck, that is acanthosis nigricans. If you check the fasting insulin levels more than 30 is again suggestive of insulin resistance. If you check the fasting glucose or insulin ratio, if it is less than 4.5, suggestive of insulin resistance. You can check the serum triglycerides which are above 55 millimole per liter, and amenorrhea. These are the one you can keep it in mind. If you see at least 3 or 4 criteria out of these 8 criteria or 9 criteria, that is enough to say that she has an insulin resistance or PCOS. Now, what is the relation of PCOS and obesity? So, obesity both independently and by PCOS exaggeration, it increases hyperandrogenism. So, it is like a additional factor which increases all the pathology. So, patient as soon as they have PCOS and they have obesity, they will have more hyperandrogenemia, they will have more hirsutism, they will have more decreased chances of natural conception, pregnancy complications. So, that's the relation of PCOS. So it is, even if a PCO patient is maybe having average weight, but as she becomes obese, she goes more deeper into this disease. So we have to counsel our patients that getting putting on weight is something not very good or good for her own disease. Also, having PCOS and obesity, there is an increased risk of impaired glucose tolerance and type 2 diabetes. So it is documented that 70 to 80% of obese PCO patient has an insulin resistance, because fat is the one of the very important reason, excessive fat for a insulin resistance. In thin patient, we document or we see only 20-30% patient having insulin resistance. So that's a difference between lean PCOS and obese PCOS. Of course, there is an increased cardiovascular disorder risk because of metabolic syndrome associated with, and obesity reduces the effectiveness of intervention for PCOS. So whatever treatment we want to plan, obese patient will have a reduced response to your treatment, and that's why obesity is something we need to understand. We need to tell our patient that your your PCO, that's why you are not having obesity. It is the obesity which is increasing your PCOS. So I think this chart we have already discussed. Coming to this management of insulin resistance, so that's very important. So let's focus on management now. So these are the guidelines which you must read. I think they are the latest guidelines on PCOS, International Evidence-Based Guideline for Assessment and Management of PCOS 2023. All the major important bodies across globe, I think they have come together and formulated these guidelines clearly regarding management of insulin resistance. It says that Metformin alone should be considered in adults with PCOS with BMI more than 25. Okay, and metabolic outcomes including insulin resistance, glucose, and lipid profile. If we want to improve, metformin should be given. So it's no more like that, even that overweight patient of 27 BMI, we should give metformin. So metformin is compulsory for such patients, and that's very, very important. Metformin alone could be considered in adolescent at risk of or with PCO with cycle regulation. Acknowledging limited evidence means beforehand, everybody, all of us used to just go on prescribing oral contraceptives. The guideline says that it's not effective. It's not getting the pathology back to normal. So, metformin, we have to, understand that it's a first choice in adolescent age group who is having PCOS. Okay. The third important point and fact about metformin is that we have to metformin alone may be considered in adults with PCOS having BMI less than 25. Now, that is all 25 is average weight or thin patients. So, even those patients, it is not like that thin PCO patients do not require insulin sensitizers like metformin. They still require. So, your GTT plays a very important role. Okay, so do your glucose tolerance test. Check for clinical biochemical evidence of all insulin resistance. If you have any of these, please do not forget, start metformin. And the maximum dose of given for adults is 2.5 gram. Okay, the maximum I'm talking about, it's not recommended dose. You can start with 1000 milligram, that is 500 milligram twice a day. Slowly you can increase it to 1500 milligram per day. So another best inositol is, best insulin side is inositols. Okay, it is said by these guidelines that inositol can be considered in women with PCOS based on individual preferences and values. Okay, because it has got a limited harm, it has got a potential for improvement in metabolic measures, and we have a very limited clinical benefits on ovulation, hirsutism, or weight. Okay, but so important is that yes, you can give if you feel that your patient is going to benefit. Yes, you can give because it shows a better menstrual regularity. Okay, it reduces the insulin resistance. Okay, but metformin should be considered over inositol for hirsutism and central adiposity. So if your patient is more like a hyperandrogenic, having obesity, I think that should be your first. The only disadvantage is that a gas GI side effect. We know that. So when you have a patient who, when you start metformin and have a severe GI side effect like gastritis, probably you can't give metformin there. Don't forget, you can use inositols in that place. Okay. Um, let's go ahead with regarding about inositol. So inositol in any form alone means only minoxidil or only DCI, or you can give a combination of MIDCI, can be considered as an experimental therapy with benefits and risk currently too uncertain. That's they say because there are not too many studies. About anti-obesity pharmacological agents from these guidelines, I just wanted to mention it here that these guidelines, they recommend anti-obesity agents like orlistat and all those drugs, GLP-1 receptor agonists for because we want to have a weight loss. Now, because we are talking about insulin sensitizers, I wanted to highlight this study in 2022 because it was little eye-opening study for all of us because 102 PCOS women, okay, they out of them 50 patients received minoxidil in a dose of 2 gram twice daily. So, friends, colleague, it remember 2 gram twice, that is 4 gram. If you look at our pharmacological combinations which are available in India, they are all having maximum 1100 if you give twice a day. Okay. But probably why we are feeling that we are not getting results, probably this might be the reason. Let's see what this paper has to. So 2 gram twice daily minoxidil was compared with metformin 1500 milligram per day. And what they realized that if you give in these doses 2 gram twice a day, the clinical pregnancy rate, cumulative pregnancy rate after one or two FET cycles, all were significantly better with minoxidil. So the pregnancy outcomes are better. So probably even minoxidil is good, but probably we were using a very low dose. So this is just a one paper. It's not, don't take it as a pinch of salt. Just wait for more evidence, but this is just for a scratching the brain idea that start using probably 2 gram twice, that is 4 gram per day. Maybe we may not even require metformin and we'll get a similar efficacy. It did say that fertilization, cleavage, and number of good grade embryos rate were significantly higher in my inositol group if you are giving 4 gram per day. So that was a randomized control trial. Again, there was one Indian trial in 2019 by Dr. Agrawal from AIMS Delhi. What they did is they combined metformin along with minoxidil, so giving both together, and that was compared with metformin alone. And they found that primary outcome live birth rate was significantly better when you are given a combination of metformin and myocetal. I think this was a study since when I am also using myself, both in combination, and my own experience is still that says that combination is much better than metformin alone. And also as secondary outcomes, if you look at improvement in menstrual cycle, that is regularity, hormonal and biochemical parameters, chances of spontaneous conceptions, those other complications like abortion, multiple pregnancy, ovarian, so all goes down, and you have a better improvement into menstrual regularity and all those parameters, hormonal and biochemical. And of course, the biggest advantage is higher live birth rate. So I think uh, I'm more happy with this. This is my experience-based suggestion. Evidence, not much evidence we have. These are only few, one or two papers. And this was another paper which was a randomized control trial in 2013, where all overweight and obese PCOS patient having age group between 18 to 35. So 27 patients received metformin as a monotherapy and 26 patients received combination. So this is a very recent study, that is metformin, MI and DCI combination. They found that menstrual cycle regularity was improved in both the groups, but it was more better with combination. Okay, as I mentioned that I also personally found better results with combination. And of course, the significant improvement into PCOS Q score, that is a kind of a quality of life score. And that was also significant better in minoxidil based therapy group. They did
Kundan,
not find much difference
Kundan,
in the hormonal. Yes,
Kedar Gandla here.
yes, Kedar.
I wanted to just add my opinion that as you said that combination works better in this. The advantage is that the dose of metformin is also limited. You don't have to increase. Myoinositol is also good, and side effect, that is the most important aspect of discontinuation of this medicine, is not there. So as you said, we start half half and
Hmm.
then go on to 1-1. It is a very good combination, and I think it's a very well tolerated and gives good results.
Thank you. Yes. So as rightly is mentioned, because we are able to use a very low dose of metformin, the side effect profile is very safe and very less. So going proceeding with another management of obesity, which we should not forget, and it's important part of PCOS management is weight loss in PCOS. I think that should be first when it comes to obese PCOS, as very typically mentioned in the literature, that if you achieve a 10% weight loss, that definitely improves the metabolic and reproductive function of the woman having PCOS. And it has to be targeted within at least 4 to 5 months. That is minimum 4 months, I will say. Literature says that at least you should be able to achieve it in 6 months. What is important? So best thing is the waist hip ratio. That is when you have a loss of abdominal fat, and that's a best predictor of weight loss. And how it improves the metabolic, basically weight loss will increase the SHBG concentration, and once the SHBG increases, it is going to bind to testosterone. So protein bound androgen levels are going to be better, but it is going to reduce that free androgen levels, which are more active and causing hirsutism and hyperandrogenic pathologies. So this is weight loss is very important. And when we create a deficit of 30%, that is intake and outcome energy deficit is of 30%, or only 500 to 750 kilocalories per day, that is enough for weight loss. So to create this, we need to do a diet modification. And typically diet should be restricted in carbohydrates. It has to have a high quality diet like enriched in fruits, vegetables, whole grains, lean poultry, fish, that should be encouraged. And low fat diet, low carb diet, and high protein diet is something which is recommended. And I think dietitian, we can take a help of dietitian for better diet chart. And at least ask your patient that 70 to 80% try and follow this diet. I know 100% nobody will do it, but I think 70-80% at least will restrict her from 500 kilocalories. That actually can lose her 1 pound weight per week. And we can also take a help of certain pharmacological agents like appetite suppressants, phentermine and sibutramine. Even this orlistat, which is available in India, it is an absorption inhibitors. So orlistat, it is also a very good drug in morbidly obese patient, especially having BMI more than 35 with comorbidities, and any patient whose BMI is more than 40, bariatric surgery should be the first option rather than anything else, because they are morbidly obese. They do have other metabolic comorbidities. We need to understand this, that there is a they will take a lot of time to go back to normal weight with diet and exercise. So these patients needs to be undergo bariatric, because it will improve her pregnancy outcome also and pregnancy journey also. So don't hesitate for your morbidly obese patient to give them first choice as a laparoscopic obesity surgery. And I think gastric bypass one of the best way of managing it. Again, we are talking about obesity and weight loss. So this pharmacological agent, which is right now very demanding and very effective, and that is GLP-1 receptor agonist. And we must understand which drugs and how to use them in PCOS. So friends, there is a reduction in the body weight because of the increasing expression of glucose transporters in insulin dependent tissues. And it also decreases inflammation, it decreases the oxidative stress and modulates the lipid metabolism. So these are the two drugs which are available, and those are semaglutide and the liraglutide. Semaglutide is the one which is available as a oral, and liraglutide is the injectable form. Now, looking at the review for these drugs in patients with PCOS for all metabolic and endocrine parameters, this was a review recently by Dr. Badar in 2024 in Women's Health Journal. It says that glucagon-like peptide-1 receptors agonists, they effectively reduce body weight and improve some of the endocrine and metabolic parameters of PCOS. And a combined treatment of these drugs with metformin has a significant effect on weight loss and favorable results on endocrine and metabolic parameters. So you can combine these two drugs, especially those patients having diabetes, having obesity and PCOS. This combination is the best for them, because GLP-1 helps to control the insulin resistance significantly and even the blood sugar level significantly. Yes, Kedar.
Kundan, this semaglutide and liraglutide, we have to stop at least 3 months before conception, isn't it?
Yes,
Like,
it is. It has been
yeah,
mentioned that
mentioned.
it at least washout period has to be
Washout.
3 months prior to your ART treatments. So that's
And
it.
another thing which I notice in my private practice, that
Mm.
at the moment with the obese PCO walks in and you start telling them about the diet and everything, they will tend to go away. Okay, so it is very, very important to understand that they give them only small, short targets, like 5 kgs only. Okay, and if you one cannot wear all the caps, please send her to a good dietitian and tell her to keep coming back for some reason or the other. Otherwise, they tend to go away because they themselves are little depressed and they have this binge eating habit. So, you want only 10% lose weight, because in pregnancy, you can allow them to gain that 10% and get your life birth correctly. So this is what I do in my practice. Otherwise, this liraglutide and the latest, the semaglutide is the best if the patient is very young and extremely obese. I think that's a wonderful drug. Thank you, Kundan.
Yeah, and important as he already mentioned, that we need to ask them, give them some target. It's like you tell them not to reduce like 5-6 kg in a month. You tell them reduce only 2 to 3 kg per month, okay, and come back at the end of another 2 months later, so that we assess that how much is reduced. And if it is not effectively reduced, we can go into detail where is exactly problem, whether she's not following diet, whether she's not undergoing a proper moderate exercise pattern, so all gym exercises. So we can go into detail and can keep a watch. So I think that's very important, and dietitian has to review do a follow-up visits with them every month. In fact, I say, because they can strictly monitor diet pattern to achieve that actual target level. So as Kedar said, you have to keep a supervision on this weight loss program. You just don't advise them and send them back and come back after 3 months, 4 months. No, I think you must call them very frequently so that there is a little motivation for them. There is a watch on them. So rightly said by Kedar. Now, let's proceed with what kind of lifestyle is better, whether pharmacological agents are better or these lifestyle modifications are better, like diet and physical activity, or combine is better before we start any infertility treatment for these patients. So they have found that only giving oral contraceptive pills is not going to be sufficient. If you look at the cumulative ovulation rate or the live birth rate, that both the parameters are better if you have advised them to undergo this lifestyle modification or OC pills along with lifestyle modification. So remember, only OC pills don't prescribe and leave it, don't tell them and give that assurity, yeah, it is going to work better. In fact, these strategies combining both will act much better. Now, coming to ovulation induction treatment for all these PCO patients, because that's the mainstay of the treatment. So before we understand ovulation induction treatment, this understand one FSH window concept. Now, I hope my marker is seen to you, but this is something which we need to understand that on the second day, typically the FSH levels are between 5, 6, 7 or maximum 8. So 5 to 8, those are the levels. Now what happens because of estrogen withdrawal, patient gets some menses, estrogen is low, and because of estrogen is low, there is an increase in the FSH and it goes beyond this dotted line, what is called as a threshold. So once on the second and third day it goes beyond this threshold, there is a recruitment of, if you go look at the down graph, there is a recruitment of 2 to 3 follicles as you can see in these black lines. Now what happens? Typically the follicle will start growing, so follicle will start producing estrogen, and as the estrogen increases in the circulatory levels, again the same principle, estrogen inhibits FSH, and over the time period, slowly over 5 to 6 days later, the FSH level goes below this threshold. Now, once it goes below this threshold, out of this recruited 2 or 3 follicles, 2 follicles will go into atresia and only 1 follicle goes into dominance. So that's how a natural cycle is planned or it is there in our body. Now, the time when it goes beyond this threshold and the time between below which time at which the FSH goes below this threshold, this duration is called as a FSH window. Now, if you keep this FSH window more wider, there is more chances of more follicular growth. Okay. So like suppose you want all 2 or 3 follicles to grow together, you don't allow that FSH to go below the threshold. So you are preventing this follicular atresia. And that's where the role of gonadotropins comes. So when you want controlled ovarian hyperstimulation, you have to keep this window wider. So then you get 2 or 3 dominant follicles. Also, we'll just finish one part here, and that is regarding IVF, that the FSH beyond this threshold, how high FSH is going will decide how many follicles to recruit. So because some in IVF, what we do, we start 300 HMG, 375 HMG. So there is a sudden increase in the FSH levels. It even it goes beyond this, what you see in this diagram. So on second, third day, the higher gonadotropins level, and that's why you have more follicles recruiting. You understand? So that is also all depends on this graph. So this concept we need to understand. Now, why clomiphene resistance used to happen? Typically, clomiphene of 50 milligram, what it is to do, it used to antagonize estrogen. So because estrogen is low, FSH will increase. But FSH never used to go beyond this threshold, and that is why there never used to be any follicular recruitment. And with 50 milligram, many times we used to see that there is no follicular growth. There is no follicular recruitment. That's because of this threshold concept. So FSH threshold, you need to understand that why such threshold, why we used to get clomiphene resistance with 50 milligram or even 100, and then 150 milligram when you used to give, then we used to get a 1 follicle growth. So because it all depends on the doses of ovulation induction drugs. These six principles, or rather five principles, you must remember or remind yourself all the time when you are planning ovulation induction. One is that elevation of FSH beyond threshold level required for follicular recruitment. So your first 2, 3, 4 days, drug doses, all is very important. Narrow FSH window, single follicular growth. Wider FSH window, you will have 2 to 3 dominant follicles. Now, this one principle you need to remember. Second, the LH acts on theca cells in follicular phase, produces androgen. LH acts on theca cells and granulosa cells in luteal phase, and it produces estrogen, progesterone, and androgens. So, see, there is a difference. In follicular phase, the higher LH, which is seen in PCOS patient, it always produces more androgens. So that is not good for a follicular phase. And that's why we say follicular growth arrest sometimes in case of very high LH levels. Okay, so that's second principle. Third, sustain high levels of estrogen. As the follicle grows, it is going to increase FSH estrogen level. So once the estrogen goes beyond certain threshold, it's going to allow LH to surge. Okay, and then if when your follicle is not yet ready and your patient's premature LH surge has happened, it is going to advance the endometrial phase, maturity phase, and we are going to have poor success rate. So remember, look at when you will have high levels of estrogen. So obviously, typically when one follicle grows, it produces 125 to 200 levels of estrogen in the blood levels. But when you have 2 or 3 follicles, that kind of level will be achieved very soon. So that's why premature LS surge happens. So typically you will see more percentage of premature LS surge happening in the cycles where you have more than 2 dominant follicles. In gonadotropin induced cycles, because they are associated with LPD because of premature luteinization. That's why they need a good progesterone support during the luteal phase. Now, typically, we have three principles of ovarian stimulation, ovulation induction. One is achieve pregnancy in the shortest time and avoid complications like OHSS and multiple pregnancy. And we have typically clomiphene, aromatase inhibitors like letrozole and gonadotropins for this aim to achieve. Now, before you plan a cycle, always check for these six parameters. What are her antral follicular count on day 2? What is her AMH levels? What is her age? Whether she is obese or lean or thin PCO? What was her previous response to stimulation, if at all available as a record? And if was there any history of OHSS, so that you know what dose she has ovulated. You can always go for the suboptimal dose to prevent OHSS. Let's understand the clomiphene and its problem. We know that the ovulation rates were high, but pregnancy rates were critically low, and that is all because of peripheral anti-estrogenic effect of clomiphene at cervical mucus and at the endometrium level, causing a poor endometrial growth. Okay, and that's what there is an increased incidence of miscarriage with the clomiphene also, and 20 to 25% of these group patients were resistant to clomiphene, as we mentioned how it was resistant, and it failed to ovulate even at doses of 150 milligram per day. So a lot of clomiphene resistance and clomiphene failure cases we noticed. Now, what is clomiphene resistance? So if you don't if you find a patient who is failure to ovulate even after receiving 150 milligram of CC daily for 5 days per cycle for at least 3 cycles, then you can consider as a clomiphene resistant cycle, and they account for 15 to 40%. That was our clomiphene, and usual reason is nothing but insulin resistance, hyperandrogenemia, and obesity. PCOS with these kind of abnormalities, you will always see that clomiphene resistance happening in this patient. So solution used to be, whenever you come across this situation, you give metformin to these patients, your clomiphene resistance will go down. You can switch to use of letrozole or gonadotropins. You can add certain adjuvants, and either you can go for some kind of last resort as a ovarian drilling. Clomiphene failure is that patient is responding to clomiphene. She was ovulated for 3 cycles, but there was no pregnancy at the end of 3 cycles, and that's called clomiphene failure cycle. Coming to letrozole, which is a very important drug, we know it is an anti-estrogenic agent. It exerts action by inhibiting aromatase enzymes, and we must understand that the conversion of testosterone to estradiol or androstenedione to estrone, these two are controlled by aromatase enzyme, and aromatase inhibitors means they will inhibit aromatase, so there won't be any conversion from testosterone to estradiol, and thus the estrogen levels goes down. So there is something called as a non-selective inhibitors and selective inhibitors. As you can see it here, the typically selective inhibitors are acting into these two pathways where androstenedione is getting converted into estrone, or androstenedione getting converted into testosterone, and then testosterone to estradiol conversion selective inhibitors will act and will not allow. And non-selective inhibitors will act at all levels, that is conversion of from cholesterol to aldosterone, cortisol, androstenedione, and even these two procedures of synthesis of estrone estradiol. So why non-selective inhibitors like those other aromatase inhibitors, but selective when it comes, letrozole is the preferred selective inhibitors. It is a third generation non-steroidal aromatase inhibitors, very highly selective aromatase inhibitors, and a very potent in its action. uh, I will not go much into detail of this, but we need to understand one very important point, that the elimination half-life is about only 2 days, that is 50 hours. Means if you have given say letrozole for say still sixth day, by eighth day the letrozole effect will go down. Means it is because the half life is only 50 hours, so that anti-estrogenic effect will go down from eighth day onwards, and you will see that there is a suddenly nice increase in the estrogen levels from eighth or ninth day onwards. So letrozole, it blocks the conversion of androgen to estrogen. So there is a temporary accumulation of intraovarian androgen, and we know that we need good androgen levels inside the follicular fluid because it increases the follicular sensitivity to the FSH levels. Letrozole suppresses estrogen. Okay, letrozole suppresses estrogen, because of which there is a upregulation of estrogen receptors in endometrium, and it increases endometrium sensitivity to estrogen. So there is a rapid proliferation of endometrium. There is a good blood flow to the endometrium. So we get a good endometrial milieu at the time of follicular maturation. Then that's the biggest advantage of letrozole over clomiphene. Another big advantage given by this trial in 2017 was letrozole combined with clomiphene. They found that in a group who received letrozole with HMG, there was a 0% of OHSS. Okay, means not a single cycle got cancelled because of OHSS. It happened only in letrozole with HMG. But there was 5 to 6% cycles with clomiphene with HMG. There was cycle cancelled because of OHSS. So using letrozole has an advantage. Whatever advantage we saw, that increase follicular sensitivity, increase endometrial growth, and good endometrial milieu, also less chances of OHSS with letrozole. So in this 2007 study, which said that with letrozole, there was higher rate of ovulation, more dominant follicles, better endometrial thickness, higher clinical pregnancy rate, higher multiple pregnancy rate, lesser adverse effect, and higher acceptability by the patients than clomiphene citrate. So these were the advantage. How can we use them? So always when you come to ovulation induction treatment, first choice is letrozole. So you give letrozole 2.5 to 5 milligram per day from second day. Please start from second day instead of day 5. You will have a better results. So day 2 to day 6, and from seventh day onwards, you start monitoring. But this is short letrozole protocol where you just give it for 5 days. There is also called as a longer letrozole protocol, that is extended letrozole protocol, where beyond even 5 days, you are given letrozole for almost 10th or 11th day of menses, and you will follow. So what will happen with extended letrozole, we need to understand is that there is a continuous FSH release which helps for further follicular growth. But the only disadvantage is that the estrogen levels which are low till 13th day. So it has been seen with extended letrozole protocol that there is a good follicular growth, possibly even better, I mean, adequate endometrium, but it would have been much better in comparison with 5 days of letrozole. Okay, so 5 days of letrozole will give a better endometrial thickness than extended letrozole protocol. So that is one, because letrozole will keep estrogen levels low. And as you are giving till 11th day and looking at plasma half-life, at least till 13th, 14th day of the cycle, the estrogen levels will be much lower. And remember, if the estrogen levels are below 100, it is associated with a higher miscarriage rate. So that's why extended letrozole, we found it effective for follicular growth. But in terms of reproductive outcome, it was not better. And that's why it was not very popular for many places. Now, clomiphene versus letrozole. So this was a kind of an individual participant uh, data meta-analysis. So what it says that in women with PCOS, letrozole alone improves live birth rate and clinical pregnancy rate. And important, it reduces the time to achieve pregnancy in comparison with CC. Now, again, CC is not a bad drug. You have to, when you want to use CC, you have to use it with metformin. Only CC, don't use it. If you want to use clomiphene, you have to use it with metformin. It also increases clinical pregnancy rate. But comparison with letrozole, the time to pregnancy, that is not so great than what letrozole will give you. And treatment effects of letrozole are influenced by baseline serum levels of total testosterone. Clomiphene with metformin are affected by baseline serum levels of insulin. So these two parameters will help you to decide where I should use letrozole, where I should use metformin. Now, this was a very good study in 21, again a randomized control trial. If you look at the type of the study, it is a assessor blind, means a doctor himself or assessor was not aware what group patient, which group of the patient received what drug. It was a randomized control trial for 90 infertile women with PCOS, and they found that the pregnancy rate, monofollicular development, mean time to achieve pregnancy was significantly better with letrozole. Okay, so I think letrozole should be our first choice. What about gonadotropins? Again, this diagram will help you, which I was explaining in the beginning, that in gonadotropins, you are keeping, because you are giving gonadotropins right from second day. So there is a sudden rise into the FSH levels in the circulation beyond threshold. And as you are giving daily gonadotropins, the levels are up, beyond above. And so there we see two or three dominant follicles growing. So that's the advantage of gonadotropins. So this is how you will plan, that you give 37.5 of IU of recombinant FSH, or even 50 IU of recombinant FSH as a starting dose. Don't directly start with 75 IU. I won't recommend you that. If it is HMG, then it is 75 IU you will start. And please give it daily. And remember, in gonadotropin cycles, you give 4 days, and fifth day onwards only you start monitoring the cycle, because sometimes you will see that with 4 days of even gonadotropins, you will have a one or two follicles which are almost at the size of 16, 17 millimeter. And that's why you have to monitor. So, or sometimes it may happen that whatever dose you have started, you don't see any follicular growth. So sometimes you have to step up the dose. So if you have started 50 IU, you can increase it to 62.5 IU, or you can increase it to 75 IU, and then you can monitor the follicular growth further. Now, typically in these cycles, because you are going to get two or three or four follicles, remember you have to watch for premature LH surge. So what I recommend usually, that when the follicles reaches 14 millimeter size, I think in that 14 millimeter size is achieved, you send the LH levels, and once the LH levels are, you receive the report. Typically, if the LH is above 5 but below 10, that is a little critical zone. And those are the patient who may go to the premature LH surge, and there you can add antagonist to prevent LH surge. Because the follicles are 14, they will take only 2 days, because gonadotropins develop the follicle at the rate of 1.5 to 2 millimeter per day. So today, if it is a 14 millimeter follicles, 2 or 3, day after tomorrow with gonadotropins, they will be 17 or 18. So that kind of, so you may need 2 or 3 maximum antagonists, not going to be very expensive cycle for them, but you get a better results because you have prevented the failure which would have happened because of premature LH surge. Now there is another protocol which is called low dose FSH. So where what you can do is, what people used to do here is to start with a very low dose of 37.5, give it for 7 days, and then 7 days later you reassess. If you don't see follicular growth, then you increase it by 25 IU, or sorry, 12.5 to 25 IU depending on the follicle size. Again, give it for 7 days. So Here, the only problem was it was very prolonged stimulation because you are giving low dose for a longer time. And that's why this used to be very expensive cycle. And usually in this protocol, because there was very low dose in the initial phase, so immediately only one follicle used to develop. So usually you will see monofollicular growth in this. And if you look at the pregnancy rate, it's in comparison with controlled ovarian hyperplasia slightly lower because there is a monofollicular growth. What are the disadvantages? As I said, it was expensive. It increased unnecessary increased consumption of gonadotropins because really 18 to 21 days stimulation was required to develop that one single follicle. Uh, Again, you need a little close ultrasound monitoring, frequent visits by the patients. So, if something which gives only monofollicular, something which can give me multiple follicular, what is the midway? So, this is something which I recommend. It is not guidelines based recommendation, but this is my experience based recommendation that you can combine oral ovulations with gonadotropins. Like we have certain studies which was done in 2013 where clomiphene for 5 days followed by HMG for 4 days was compared with pure gonadotropin cycle, and they found that there was no significant difference between both the studies in terms of endometrial thickness, number of mature follicles, peak estrogen before SCG injection, and number of cases that landed in OHSS. So what was the advantage? So doses, if you look at the dose of gonadotropins when clomiphene was used, it was significantly lower. Obviously, the expenses are going to be lower. And pregnancy rate, it was more significantly better when CC and HMG was used compared to only HMG. So adding HMG to the oral ovulations like clomiphene works better, reduces the consumption of gonadotropins. Again, similar, the same which I mentioned when letrozole was compared with clomiphene. In this protocol also, letrozole was combined with HMG, and another group received clomiphene with HMG. And they found that letrozole with HMG has got a better endometrial thickness, better pregnancy rate, and even better clinical pregnancy rate, and at lowest risk of OHSS. This was another study in 2015 when one group received letrozole with HMG, second group received clomiphene with HMG, and third group was only HMG. And even in comparing these two groups, in terms of monofollicular rate, number of follicles more than 14, cycle cancellation rate due to hyperresponse, HMG dose needed, duration of treatment, all these parameters, letrozole with HMG was more effective than even clomiphene with HMG or HMG. So we did our retrospective analysis. Just wanted to share with you my experience of using letrozole with gonadotropins, and what we realized that our 143 out of 143 patient, we got almost clinical pregnancy rate of 17.48% per cycle I'm talking about. But when we compared cumulative pregnancy rate per patient, we got it almost 31%, and it was pretty high. And also the gonadotropins consumption probably with comparison with gonadotropin cycles, it was like 5 versus 10 to 11. So that was a big difference. Means we required when we use letrozole, it was only 5 or 6 days we required HMG. And when we use gonadotropins levels, we required almost for 9 to 11 days. So consumption of gonadotropins can be less with using oral ovulations with. So how you can use them? So these are the two protocols. One is that you can give letrozole 2.5 milligram or even 5 milligram from second day to day 6. And seventh day onwards, you add HMG. Either you can add 75 IU or you can add 150 IU depending on number of follicles and the size of follicles. From seventh day onwards, give it daily and monitor every 2 days later. Okay, depending on the follicular size. In these protocols, remember when you add gonadotropins, your each follicle will grow by 1.5 to 2 millimeter of follicle size by day. So if I am seeing 12 millimeter follicles 2 or 3 today, less likely they will be 18 in 2 days. You can call her after 3 days also. If you want to monitor LH, you can call them within 2 days. And once the follicles are beyond 14, 15, you can check the LH just to detect the premature LH surge in time so that you can use antagonists. But so that's how you will call their visits. So this is one protocol by which you can have one or two dominant follicles. Now, there is also one protocol which I personally use my practice, which I will suggest with all of you that you can try if you haven't tried this, where you can use letrozole 2.5 milligram only on day 2 and day 3. Here we use a FSH window concept. So letrozole increases the FSH beyond threshold. So there is a follicular recruitment. So we are not allowing it to grow too high. So we only get 2 or 3 dominant follicles because we are giving just 2.5 milligram. Then fourth day onwards, we add HMG. We add HMG in a dose of 75 IU to 150. Especially in a PCO patient, I will recommend 150 IU from fourth day. Okay, because we need to maintain those gonadotropins levels high above that threshold. So we allow those 2 to 3 follicles to grow continuously into the cohort or into the dominance, and we get at least 2 or 3 follicles ovulation at the after the trigger, and we increases the chances of pregnancy. The data which I shared with you, which was my own hospital data, we use this protocol: letrozole for 2 days followed by HMG every day from fourth day onwards. Once you start using them in a lot of patients, you will realize that it is working effectively. Now, in few patients, when you have given 2 days of letrozole and 3 days of HMG, when you monitor on seventh day, if you feel that with 150 IU, I have 5, 6 dominant follicles, seventh day, you can reduce from 150 to 75. Believe me, your at least 3 or 4 follicles will go into atresia. Only 1 or 2 follicles will go ahead. So monitor on seventh day carefully. If your adequate number of follicles are there, you please continue 150. But if it is beyond like 4, that is 5, 6, 7 number, step down the HMG dose, and you will see immediate response in there that the follicles are going into atresia and you are not having hyperstimulation. In fact, not hyperstimulation, it is like a more than adequate stimulation. So this is one way. You can also use similarly clomiphene citrate. This we used to use it in when the letrozole was banned in India. So what we used to do, we used to give clomiphene only for 2 days, and fourth day onwards only we used to add HMG. Now again, remember the clomiphene half life is 5 to 7 days. So only second and third day we have given clomiphene. This used to wash out by eighth or ninth day. So clomiphene negative effect used to wash out and only gonadotropins are there. And that's where again we used to get a similar result like this. But again, after the letrozole was allowed, we replaced clomiphene with letrozole for all those advantages which we discussed in previous slides. Now, premature LSH is something which we need to understand. I know a lot of our colleagues, they don't use antagonists, and I think I am using it since almost last 12 years. And I'm convinced, and even this meta-analysis in 2014 has convinced that if you use GnRH antagonist for patients undergoing controlled ovarian hyperstimulation and IUI, they significantly increase your clinical pregnancy rate because they prevent premature LS surge. So your endometrial advancement doesn't happen. It decreases the pregnancy loss rate. Again, it is because of the endometrial advancement or luteinization of endometrium. And that's why it is very, very effective in using. So as I said, as soon as the follicle reaches 14 millimeter, you send the LH levels. So LH below 5, no need to worry. LH between 5 to 10, give antagonist on the same night and continue daily till your trigger, that is when the follicle is 18 to 19. Coming to the trigger now, in IUI for such PCO patient, what trigger you will give? Okay, so this is a good kind of a paper in long time back, 2008. In this patient, they documented that when you give a trigger at 13 to 15 millimeter, you get only 72% chance of mature oocyte, that is meiosis 2 oocyte, because our SCG converts from meiosis 1 to meiosis 2. So 16 to 18 millimeter follicle, if you give a trigger, there is a 79% chance that you will get a M2 sites. But if you give trigger at when the follicle is 18 to 19 millimeter, 90% chance that your follicle will be M2 site. Okay. So this is one way that you can check the when to give trigger. Which trigger is better, whether urinary or recombinant? I think there's no difference, but because of the consistency of batch, I think recombinant SCG is something which I will recommend all of you to use for all IUI cycles as a trigger. Can we use dual trigger in IUI treatment? So this was a randomized control trial in 2017 where they received 0.1 milligram of GnRH agonist as a trigger, and another group received only SCG. So what they found that pregnancy rate was higher in group 1, but that was not statistically significant difference. The incidence of ovarian stimulation syndrome was not different between two groups. So even dual trigger, only agonist trigger can be very effective also, even if it is slightly hyper high response. This is the study about dual trigger. Extremely sorry. This is the study in 2023. It was studied in IUI, where one group received 0.1 to 0.2 milligram of GnRH agonist, that was decapeptyl, along with 6,000 IU of SCG, and second group received only SCG. So here they found that dual trigger is associated with higher outcomes, like live birth rate was significantly better, clinical pregnancy rate was significantly better, then multiple pregnancy rate was significantly lower with dual trigger. So it was in all the sense it was better. So even in IUI, do not hesitate to use dual trigger. It gives you better outcome. This was regarding a PCOS group. Now, I am not going into detail of luteal phase support in these groups, but just a quick word. In all IUI cycles, what you can do, I prefer giving dydrogesterone along with natural micronized progesterone for both the advantages. We need a good circulatory levels. So vaginal progesterone may not reflect into circulatory levels, but if you give oral dydrogesterone, you will have a better circulatory levels. So what I do in as a luteal phase support in these patients, or I recommend, or even the literature supports this protocol, and that is that you give 10 milligram 3 times a day as a dydrogesterone per day for 14 days from the day of ovulation, along with natural micronized vaginal progesterone capsules, 200 milligram 3 times a day for 14 days. That is from the day of ovulation. So that is the good support. You will not have cycles where you will have a lower progesterone levels in luteal phase, which landed in miscarriage. So this will definitely give you adequate luteal phase support to achieve that pregnancy for a successful outcome, and you will not have miscarriage because of luteal phase defect. Second, which is most common cause, is a second most common cause of anovulation is a thyroid disorders, and hyperthyroidism and hypothyroidism both can cause anovulation. It is the hypothyroidism which is very common, and again hypothyroidism is divided into two. So overt and subclinical. Overt is something where your TSH level is above 10 MIU per liter and having also less concentration of T4 into the circulation. So even T4 is low and TSH is high, that is above 10. A subclinical hypothyroidism is where your TSH levels in the circulation are between 4 to 10 MIU, but your free T4 levels are absolutely normal. Those are called subclinical. Now, how does hypothyroidism affects fertility? So there is an increased production of thyrotropin releasing hormone. See, because of hypothyroidism, because of the positive feedback system, the TRH is released from the hypothalamus. That leads to increased prolactin production, and hyperprolactinemia actually impairs GnRH personality, and there it affects the pituitary axis or hypothalamus pituitary axis and ovarian dysfunction, and it also causes the luteal phase defect. So this is how hypothyroidism will interfere into anovulation. Now, when you see subclinical hypothyroidism, I will revise. Subclinical hypothyroidism is TSH between 4 to 10 and your free T4 levels are normal. Okay, here the starting dose can be between 25 microgram to 75 microgram per day depending on TSH level. So what I do, just to simplify for you, this we discuss with endocrinology. If your TSH is between 4 to 5, you start 25 microgram. If it is between 5 to 6, you start 37.5. If it is between 6 to 7, start 50. So every increase by one number into TSH level, you increase the starting dose by 12.5. So you can, depending on this, you can start the doses. So that's a simple practical way you can do it. Now, where levothyroxine therapy is recommended. So those who are overt hypothyroidism, that is TSH more than 10, and also those patients of subclinical hypothyroidism where the TSH level is 4 to 10 but having TPO antibody positive, it is recommended that we have to start levothyroxine therapy in any case. Now, levothyroxine therapy can be considered for antibody negative women but having TSH between 4 to 10. So it is recommended, but it is suggested that you must give for all subclinical hypothyroidism patients. Okay, but even if the TSH is normal, that is 2.5 to 4, but having TPO antibody positive, still I think levothyroxine is recommended with lowest dose and get the TSH below 2.5 in these patients. Where levothyroxine therapy is not recommended when you have TSH below 4 and TPO antibodies are negative, you need not give any thyroxine supplementation. So, what is the correct control of TSH with thyroxine or supplementation? So, this was a good study where impact of preconceptional serum thyroid stimulating hormone values ranging from 2.5 and 4.5 on live birth rate. So, one group had TSH level between 0.27 to 2.5. Those were 543 patients, and another group having between 2.5 to 4.5, 183 patients. So they found that in euthyroid women undergoing ovulation induction gonadotropins and IUI, the range of preconceptional serum TSH values between 2.5 and 4.5 is not associated with lower pregnancy rates when compared to TSH level between 0.3 to 2.5. So they said that the parameters like duration of ovulation induction in terms of days, total gonadotropin dose, number of follicles available for trigger, clinical pregnancy rate, live birth rate, miscarriage rate was not different. So when you are planning for IUI treatment, at least try and get the TSH level below 4. That is very, very important. Once she gets pregnant, then you fresh check as soon as the test is positive. And in case, because in first trimester is recommended to get to less than 2.5. But before IUI, you can even get the TSH below 4 is sufficient enough because it will not affect your outcomes of your treatment cycle. So again, this is a quick chart which is showing you the same, that whenever you see elevated TSH, measure free T4. If it is normal, it is subclinical hypothyroidism. Then you check for TPO antibodies, that is uh, thyroid peroxidase antibodies. And if you have antibodies positive with symptoms, then levothyroxine is recommended. If the antibodies are negative, if she is asymptomatic, then probably just look at the TSH levels. If TSH are above 4 and less than 10, you treat it with levothyroxine. If the levels are below 4, don't do anything. Just do an annual checkup and keep monitoring the TSH levels over the time period. Now, if you have a overt hypothyroidism, that is elevated TSH beyond 10 and the free T4 is also low, then in that case, check the antibody status. Antibody positive patients, you have to give levothyroxine as per the weight. That is 1.6 microgram per kg, and she has to take on empty stomach daily. That's a usual recommendation. But remember, the starting dose 1.6 microgram per kg is the recommended dose, where it usually goes somewhere close to beyond 75. That is 75 to 150 is something what is usually the starting dose comes into the role when the TPO antibody is positive. In over diabetes, if the antibody is negative, then you check for other causes of hypothyroidism. Then you can take a help of endocrinologist in this case. Hyperthyroidism in males is very significant because there is a elevated SHBG levels because of hyperthyroidism, and that actually increase total and bound testosterone. The free thyroxine is transiently reduced or normal, and high estrogen and enhanced peripheral conversion of these androgen to estrogen happens in these males. And there are symptoms and signs of estrogen excess in these males of hyperthyroidism, where you may see gynecomastia, you may see commonly in fact decreased libido, erectile dysfunction, spider angiomas and spermatogenic dysfunction. Even the premature cessation of Sertoli cells proliferation is also common. So in males, always check for TSH level when you come across kind of male infertility. Treatment of hyperthyroidism is quite simple. The drug of choice is propylthiouracil or carbimazole or methimazole, and the starting dose gradually reduced by titration, because as we know that hyperthyroidism patient, especially those are autoimmune, they land up in hypothyroidism over the time period. So monitoring every 4 to 6 weeks after starting the treatment, and check the levels, and dose is titrated based on free T4 level. In subclinical hyperthyroidism patient, means the TSH level is very low, but the free T4 is normal. So no anti-thyroid treatment is required. You just follow up after 6 to 12 weeks with TSH and free T4 monitoring. So subclinical hyperthyroidism, there is no need of any anti-thyroid drugs. So how do you treat them? What are the doses? Usually propylthiouracil is the most commonly used drug. It is given as 100 to 150 milligram 8 hourly. And sometimes you can use a carbimazole also 15 milligram in divided doses. The target levels are TSH has to be between 0.1 to 0.4 with free T4 between 2 to 2.5. That's also sufficient enough to control with the drugs. After control of thyrotoxicosins, propylthiouracil will be reduced to 50 milligram QID dose. So it will be like 200 milligram per day. See, you have started almost 450 milligram per day, and now you have reduced it to 200 milligram per day. So if clinically euthyroid means clinically there are no symptoms, then PTU reduced to 150 milligram per day, and then after 3 weeks to 50 milligram BD. So you have to keep reducing as per the levels, and PTU is the preferred in first trimester if the patient still goes into pregnancy with hyperthyroidism, and it is safe to use PTU in first trimester, or can be shifted to methimazole or carbimazole in second trimester, because if you use methimazole in first trimester, it is associated with some teratogenic effects. Beta blockers are something which will use it in kind of in thyrotoxicosis patients where we want to rapidly control. You can give propranolol 20 to 40 milligram TDS, or you can use atenolol, which is safe in pregnancy, 50 to 100 milligram per day. And if there is any if your antithyroid therapy is failed to control the disease, only in second trimester surgery is indicated. The third last two slides, and that is hyperprolactinemia and anovulation. So how can you diagnose hyperprolactinemia? So single measurement of serum prolactin, a level above the upper limit of normal, confirms the diagnosis, and typically the cutoff is 26 to 27. Dose levels are sufficient. Anything beyond this is a hyperprolactinemia. Usually in patient with asymptomatic hyperprolactinemia, you assess for macroprolactin, because macroprolactin also gives you false positive results. So when there is a discrepancy between a very large pituitary tumor and mildly elevated prolactin level, serial dilution of serum samples to be assessed for eliminate an artifact that can occur with some immunoradio metric assays leading to falsely low prolactin value. So serial is something where you every after 1 hour you take three samples and give it to the lab, and the lab will check those three serial levels, and they will confirm whether your high prolactin level is whether it is a false positive or a true positive value. What is the medical treatment for hyperprolactinemia? And that is cabergoline. You either administer once or twice a week. Usually twice a week is recommended. You start with 0.25 milligram twice a week, or sometimes you can give zero point 0.5 milligram once a week also. So bromocriptine is another alternative where you can't give cabergoline, or it was probably a second choice drug. It is administered twice a day. It needs a daily administration, and 2.5 milligram orally at bedtime or twice a day. You can give a maximum up to 15 milligram per day in terms of according to the levels of prolactin. Now it has been clearly shown that cabergoline is more effective than bromocriptine, and it is also well tolerated than bromocriptine in hyperprolactinemic patients. And 8 randomized and 178 non-randomized studies over 3,000 patients were analyzed, and they felt that in comparison with no treatment, dopamine agonist significantly reduced prolactin levels and persistent hyperprolactinemia, and cabergoline was more effective than bromocriptine in reducing this persistent hyperprolactinemia and leading associated amenorrhea, oligomenorrhea, and galactorrhea. So once you see prolactin levels high, you give cabergoline for 6 weeks in a given dosage. 6 weeks later, you check prolactin levels. Usually they are under control, but if they are even high, like more than 100, so you do a MRI. Usually there is associated pituitary adenoma. If the pituitary adenoma is more than 1 centimeter, which is called microadenoma, you have to consult endocrinologist. If means you have to give it for a prolonged period. You cannot stop capgulin because she will always have a hyperprolactinemia. Even if it comes back to normal, it again gets rise within a month's time. So in adenoma patients, you have to continuously administer till she gets pregnant. And once she gets pregnant, you can even continue if it is required, or you can just monitor and decide whether she needs cabergoline or no. Though the high prolactin levels are not detrimental for pregnancy continuation, and you can stop prolactin even if she's pregnant and even if she's hyperprolactin. But remember, the levels between 27 to say 50, 60, probably you don't need to do MRI. Those are the other non-tumor causes of hyperprolactinemia. But anything above 50, 60, do MRI and check for pituitary adenoma, because that's the most common cause for having so high levels of prolactin. And depending on the size, you can decide duration of the cabergoline treatment. So friends, successful people are not gifted. They just work hard, then succeed on purpose. Our greatest weakness lies in giving up. So don't give up. The most certain way to success is always to try just one more time. So whatever we discuss, the evidence based, experience based, unless and until you try, you're not gonna have that confidence on your success, which you are eventually going to come. And that's why, please understand how to evaluate, how to manage, and how the success comes. If you follow this evidence based medicine, believe me, you will have similar success what everybody we are all getting into our practice. So this was all about anovulation. I tried covering up, though it was extensive, but I thought of that we can touch upon this subject here itself, so that because it's a very common condition in our infertility practice, and there were lots of situations which we come across in this group of patients. So if there are any questions, we can discuss. I can. There is no problem in discussion. So it all depends on your availability of time. Thank you very
Yeah,
much.
right. Kundan, wonderful. It was a wonderful talk. And I think there are about 40, 50 people have already attended, and these 40, 50 people have decided not to give up. And they're all going to be successful in their infertility practice, surely. I mean, they got instigated by the loads of knowledge that you have given to them. There are two questions which people have asked. I'll take those questions and a few questions from my side, because I told them जो भी डाउट है क्लियर कर लो, even if it is the silliest of the question. So मेरी तरफ से some silly questions will come. But the first question here is that has come. Let me see the chat box and I'll let you know the question. Uh, a role of weight loss in thin PCOS patient. This is
Okay.
somebody has asked that.
Yes, I think you don't need to advise a weight loss, especially for thin patient. And now, when we say thin patient, that is BMI below 20. So probably doing a further weight loss is not going to help for such patients. So weight loss is typically for anybody whose BMI is above 25. So check for the BMI. So that's number